I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Well, good evening and Happy New Year to everybody. We all hope for a great 2026. So welcome to the January 14th, 2026 regular meeting of the Washington Township Healthcare District Board of Directors. Public notice for this meeting has been posted appropriately on our website. Tonight's meeting is in person and is also accessible by Zoom. I ask that you please mute your system until such time as you need to speak. Cheryl, if you take the roll.
Director Nicholson?
Present.
Director Yee?
Present.
Director Stewart?
Present.
Director Eapen?
Present.
Director Wallace?
Present. Very good. We'll go on to oral communications. Members of the public are invited to speak during oral communications. When prompted, please state your name for the record. Then proceed with your statement not to exceed 3 minutes on issues or concerns not on the agenda and within the subject matter of jurisdiction of the board. Are there any members of the public who would like to speak at this meeting? Seeing none. Cheryl, are there any written communications?
There are no written communications.
Very good. We'll now move on to our consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under the action item heading of the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? Seeing none, does any member of the public want to remove an agenda item from the consent calendar? Seeing none, may I have a motion to approve consent calendar A?
I move that the Board of Directors approve the consent calendar item A.
Do we have a second? Second. Second from Mr. Wallace. Cheryl, if you would roll call vote on that.
Director Nicholson?
Aye.
Director Yee?
Aye.
Director Stewart?
Aye.
Director Eapen?
Aye.
Director Wallace?
Aye. Thank you. The consent calendar is approved. Okay, we're going to have a educational session.
Yes, so this evening, Paul Kozachenko, that all of you know, our Washington Health Legal Counsel, who has been our legal counsel for decades now, and with Gonzalez and Kozachenko, is going to provide us with the information on the Brown Act updates that are going into effect or have gone in.
Okay. Yeah, I can tell you to move it. Go to the next slide, you know, when you... Oh, that's great. Okay. So, good evening. Yes, they changed the Brown Act. Probably the most changes that have been made in quite a while. So, this is going to be fairly high level. There's going to be, there is one particular change that I think you'll all find was a positive change for us. There's some other requirements I'm going to go over again at a high level. So you have an idea of the changes, but we're going to, and you also have to, as this agenda shows, there's some changes that go into effect January 1, and there's some other changes that are going to apply in July to what they call legislative bodies. And because of our size, we're going to qualify as that. Not every entity does, but we do. You have 1,000 full-time employees, you qualify. And there's some other requirements that will apply then, but we don't really have to worry about those now. So with that, let's go to the next slide. The next slide. Okay. I'm sure you're all very interested, for those of you who are very active on social media, that the legislature has now clarified that participating in conversations with constituents on social media is not a meeting. So you're free to do that. But if you find out that 2 other board members are participating in the same conversation in social media and you're discussing hospital business, you can't do that. Okay? Yes, a total of 3. But otherwise, they clarified that you can now participate in social media to respond to constituents if you so choose to do that. The next one, go to the next slide. Okay, mandatory Brown Act training on distribution of material. Sorry, you should just say, we have to give you a copy of the Brown Act. Okay, so we will do that. That we're supposed to provide. It's actually in the law, even though everybody knows where to find it. We have to give you a copy of the Brown Act, and we will do that. And Cheryl, I'll work with you to, there's lots of sources we can get a copy of the Brown Act. Okay, next one. All right, these are some of the other changes that they've made or clarified. They reaffirmed the right to record meetings. This was not, in my view, a particularly controversial situation, is that people did have a right to record the meetings. That had been the law, but they emphasized that that has to be done, allowed. There is disability accommodation, so this is, again, we do provide a link on the website, not a link, but we describe that we have some disability if someone asks. So I don't think this, quote, expansion is earth-shattering for us, so we should be fine there. And there is the teleconferencing framework, which has been clarified and reorganized. The remote policy that we have regarding your remote participation is really no longer applicable, but I'll get to the details of the new law, which I think you'll find will be very more flexible for us. Okay, next slide, please. All right. So, as I said, the old policy was based on AB 2449. That's no longer there. So there's a couple of things that were done. There's some very special statutes that were code sections that are really not going to be applicable to us. But number one, if there's someone on the board with a disability, then that person can attend remotely all the time, and we don't have to worry about a quorum requirement. That's one change, and that was largely driven because the Attorney General issued an opinion that said that had to happen to comply with ADA. The other thing that they changed, they've adopted something called a hybrid meeting. Okay? So let's go to this is it, hybrid meeting. So if you recall, under the old law, if you were to attend remotely, you had to be somewhere post-notice, give advance notice, and be in a public place. Now, there's a specific code section that deals with what they call a hybrid meeting. And this is a meeting that contains two-way audio-visual. And fortunately for us, we've been doing a hybrid meeting format for quite a while, since COVID. That is, our system allows for public participation through Zoom. If a board member is to participate, they're going to be on the same system. And so we have been essentially, every time we meet, and this is not all agencies, we conduct a hybrid meeting. Some do not do this. They force you to come, but this is what we do. So we don't really have to change anything in the way our format of the meeting goes. But for the members of all of you, you can attend. We'll draft a policy for this, but basically it requires just cause, but much better than it was before. Okay? And so I'm going to go over those details right now. So members have to notify the body as soon as possible, including at the start of the meeting, if they need to participate remotely for just cause. So if you qualify for just cause, you can just notify 5 minutes before the meeting starts. And that satisfies that requirement, as long as we stay on the current Zoom system. There's a limit to how many times this can happen, but because we conduct a number of regular board meetings that we do, each of you can do this 7 times per year, use this statute. The meeting minutes have to require what the just cause is. You don't have to disclose any kind of medical details. That is one of the reasons for just cause. If you're somewhere where there's another adult present, you have to disclose that the adult is present in the room and what their relationship is to you. I think this is an attempt to prevent a public official from having someone basically advise them about what to do, et cetera, in a room. So you're basically controlled by someone else. That's why that requirement is there. Okay, here are the reasons. Child care or caregiving. So child, grandparent, grandchild, sibling, spouse, domestic partner, that qualifies. Contagious illness. So you have a cold, as far as I know. We have doctors here who can tell if that's clinically correct, but if you do, then you can say you have a contagious illness. All that's required for the minutes would be a medical reason. You don't have to even specify a contagious illness. Physical or mental condition, that's pretty broad. Probably be if, you're in a wheelchair for some reason or in crutches. The reference there to the disability accommodation, again, this would be if you had a more serious disability that generally prevented you from participating in a meeting, and we would be using a different code section. Official business travel, so this is not your... This would be travel because of Washington Hospital, as opposed to just your own travel. An immunocompromised family member, physical or family medical emergency, and then there's military service obligations. So I think that the good part is I think they've simplified this. And because this is, again, we're fortunate we've continued this practice since COVID, you will have more flexibility this year if you cannot attend a meeting in person and you have one of these just cause reasons. Okay. This would be requirements for legislative bodies. This would be, these kick in July. And we would qualify because we have more than 1,000 full-time equivalent employees. There's one other criteria we would qualify under based on revenues, but clearly we qualify here, so we will have to comply with these. Next slide, please. Okay. Two-way remote access, we already do that. Agenda translation. So if there are more than 20% more of the residents that with limited English proficiency, then there's going to have to be an agenda translation. Now, that data that comes from that, I think, comes from the community needs assessment, and I don't know that we're going to have that issue here in our community, but if we do, we'll comply by July. There's additional, there's going to have to be a disruption policy adopted formally. That is that with these contemplated, because they want this hybrid meeting to occur for all the legislative bodies, they want a policy in case the internet is interrupted. What do you do, et cetera. We probably should have that policy anyway. But basically, as you can imagine, the requirements is you have to come back. You have to warn people. It depends on, you can adjourn the meeting after a certain time, but we don't have to worry about that exactly right now. But they want that disruption policy. Community outreach. This is an interesting one. They want to make sure that underserved groups are informed about the agenda and the meetings. So now this is a pilot project. There's no penalty for not complying, but they want there to be a community outreach. So if no one's attending the meetings, then they want us to do something affirmatively to encourage people to attend meetings. We'll see exactly what we're required to do. Let's see. Other notable changes. Let's see. So there's some issues regarding public comment exemptions. This doesn't really apply to us because we don't meet in committees. Would be this is a specific code section that deals with if there's a board committee and someone spoke in front of the committee. There are public agencies to say, well, you've had your chance and you can't speak again, and basically, no, you're going to basically have to allow if you had that. We don't meet in committees, it's not going to apply to us. There's a specific new closed session exemption for cybersecurity. And then there's some technical cleanup issues that I don't need to spend any time here talking to you about. It's about how the website is configured, et cetera, and to the extent that we need to do anything, we'll just do that. So the next steps, prepare a board policy for the remote meeting and for you to consider probably in the January meeting. I'll work with Kimberly, Cheryl, and Shirley to make sure we have any of the technical changes done, and we'll make sure that you get copies of the Brown Act.
Yeah. Sounds like a little bit more flexibility.
Yes.
And maybe a little translation or a little outreach, but
Maybe.
Not excessively burdensome.
Not excessively burdensome, no.
Very good. Any questions for Paul? No. Thank you. Thank you, Paul. Look forward to the policy. All right. I'll move on with our agenda and the medical staff report. Is Dr. Berry with us?
I am.
All
Good
right.
evening.
Good evening. Happy New Year, Dr. Berry.
Yeah, same to you. Welcome back. Hope everyone had a very nice break. So I'll talk a little bit about the composition of the medical staff, and then I just have a few general updates after that. This month, in January, we have 7 new applicants to the medical staff across a range of specialties. 4 of those are physicians. 1 is a nurse practitioner, 1 is a PA, and there is a dentist who's also applying. I'll give you more details once applications are fully processed next month. Currently, we have 690 medical staff now on the hospital medical staff. And that continues to slowly grow each year and each month. If you're to add up all the active and provisional physicians and APPs, we're up to 496. So closing in on that 500 threshold. I'd also like to welcome 11 new members to the medical staff. We have Meghana Venkata Baku, who's a nurse practitioner in the family medicine department. She's joining the Washington Health Medical Group. We have Dr. William Convalescer, who's an internal medicine hospitalist joining Sound Physicians. We have Sarah Dostmalchian, who is an interventional radiologist with the ARIA group. We have Lee Wong, who's an internist joining Sound Physicians. Jiahui Lin, who's an ear, nose, and throat specialist joining with Palo Alto Medical Foundation. We have Dair Yashil Patel, who's an interventional radiologist, also with the ARIA group. We have Amarcine Mikhail, vascular surgeon with ARIA Vascular. Ann Yufa, who's a vascular surgeon, also with ARIA Vascular. Tejpal Singh, who's a teleradiologist joining Washington Radiology Medical Group. And we have 2 additional teleradiologists with StatRad. That's Dr. William Stanton and Dr. Lonnie Bargo. So we welcome all those people to the medical staff this month. As for some general updates, I mentioned this last month, but we're trying to get the word out that the urgent care center is open. So I'm making sure to mention that everywhere I go. They opened in mid-December, are open 7 days a week. And once we get things running, we'll revisit the opening hours of the facility and decide if we need to change them. You may have noticed during my report that I mentioned a couple of positions with ARIA. ARIA is an interventional radiology group that has joined the hospital and started in December. The head of that group is named Dr. Khanna. We are also expanding the offerings of our structural heart program. We're going to begin doing a procedure called a tri-clit, which is a treatment of a valve on the right side of the heart. So we already have a couple different treatments available for the mitral valve and for treatment of atrial fibrillation to help prevent stroke. But this will be a new offering, and we're going to be doing those first procedures, I think, next week. We've also accepted delivery of the Ion robot, which is a device you may remember was part of our fundraiser for Top Hat this last year. And we've accepted the device. We still need to buy some additional equipment to be able to start doing cases, but the target date for the first case will be in early February. And then lastly, we bid a fond farewell to our longtime medical staff attorney, Jay Christensen, who retired at the end of last year. And we have now started working with Aaron Mullenberg, who is part of Polsinelli Law Group. They're based in Southern California, but they're very familiar with the whole state and all the regulations and nuances of California state law. And then Polsinelli Law also has offices coast to coast. So even if they have to deal with other federal law or other things like that, they have colleagues they can talk to and get information. Those are all of my updates, and I'm here to take any questions.
Thank you, Dr. Berry. Any questions for Dr. Berry? Okay. Well, we wish you a very successful 2026. I know you've got a lot on your agenda. So.
I do. Well, same to all of you, and have a great evening.
Okay, you too. Thank you very much. All right. Sheila, EJ, Service League report.
Good evening, everyone. Happy New Year to all of you. I'm pleased to share updates on the work of our volunteers. In December, 317 Service League volunteers contributed a total of 2,936 hours across various hospital departments. Looking more broadly, from January 2025 through December 2025, 655 volunteers supported the hospital, contributing 29,516 hours over the calendar year. On December 31st, Service League volunteers gathered for a New Year's social. We enjoyed good food, reflected on the past year, and celebrated the camaraderie that sustains our volunteer community. During Christmas week, the Service League distributed over 50 individually sealed activity packets to patients to bring cheer during the holiday season. Each pack contained coloring pages, Sudoku and crossword puzzles, along with crayons and pencils. These small gestures were received very warmly by our patients. Alongside these activities, our volunteers continue to contribute in other ways. One of our high school volunteers used his crocheting skills to support the hospital's newborns. Since joining the Service League in July 2025, he has volunteered in the lobby 2 to 3 times a month. He has crocheted several baby blankets and bonnets, eventually focusing on bonnets for greater efficiency and production. He's a senior at American High, and he plans to pursue a career in nursing. His experience certainly shows us how personal talents and interests can be turned into meaningful volunteer contributions. On New Year's Day, January 1st, 3 of our NODA volunteers sat vigil with a comfort care patient who had no family. I was one of the volunteers and the last to sit with that patient. It was a quiet and humbling experience that reinforced the importance of simply being present for someone in their final moments. Moments like this remind us of the impact our volunteers have every day, and we look forward to celebrating their contributions at the annual meeting. Speaking of the annual meeting, I hope you can all join us on Tuesday, February 10th in the Conrad Anderson Auditorium. During the meeting, we'll reflect on the past year, recognize our volunteers, and nominate and elect the new board. I look forward to seeing you all there. Happy New Year again. If you have any questions, I am ready for it.
Thank you very much, Sheila. Happy New Year to you, and
Thank
Happy
you.
New Year to all of the volunteers. Your work is just so appreciated and really reflects the culture and heart of our community and this institution. So I look forward to February 10th and meeting with all of you. So you can count this as an RSVP from me.
Thank you. That's a public
I'll be there.
RSVP, and I'll take it.
It's one of my favorite meetings of the year.
Yes.
As I'm sure you've heard that before.
Yes.
Any comments or questions for Sheila? All right. Thank you so much, Sheila.
Thank you,
take
Dr.
care.
Nicholson. Happy New Year.
Happy New Year to you. All right. We now have quality report, critical care update, which will be given by Dr. Omida Zizarad.
Yeah, and I know Dr. Shariat is also on, so I will just give an overview of both of their backgrounds. They've been with us for a number of years, but they are co-medical directors of critical care, the intensivist program, and the intermediate care units. Dr. Omid Azizrad attended SUNY Binghamton, New York for his undergraduate studies and Albert Einstein College of Medicine, Yeshiva University for medical school. He completed his fellowship training at Stanford University Medical Center, and he has been with Washington since 2008. He's board certified in internal medicine and critical care medicine. His hobbies are spending time with his wife and children and traveling. He's also serves as chair of the critical care committee. I'll also introduce Dr. Cyrus Shariat. He was raised in the Bay Area. He attended UC Berkeley for his undergraduate studies and UC Davis for medical school. After finishing his critical care training at NYU, he returned to the Bay Area and has been working at Washington Health since 2011. He is board certified in critical care, pulmonary, and neurocritical care medicine. And he also serves as chair of the PNT and bioethics committees at Washington Hospital. So I will turn it over to both of you. I really appreciate your partnership and work with us and part of the intensivist program for many years.
Thank you. Thanks for having us. So let's get started on the next slide. So a brief overview of our intensivist program. It is an intensivist-led model, which means it's also referred to as a closed ICU, which means that rather than us being a consultative service, we are the primary physicians for all CCU patients. We do provide 24/7 coverage for patients in a CCU, as well as consultative services for critically ill patients across the hospital. There are 2 critical care physicians working per 12-hour shift. We have 9 full-time intensivists and 7 part-time. We are all critical care board certified, but there's also a diversity of our background as there's multiple different other board certifications as well, including internal medicine, pulmonary, neurocritical care, emergency medicine, anesthesia, nephrology, and sleep medicine. Next slide, please. What is our program mission? To provide timely, high-quality, evidence-based critical care services, to collaborate with a multidisciplinary team to optimize patient outcomes, to engage in regular education of staff on evidence-based standards of care and clinical reasoning skills, and to proactively involve family members for updates and to facilitate decision-making. This slide shows our admissions, total CCU admissions per year over the past 5 years. Just to describe the trends a little bit, in 2022 and 2023, there was a slight decrease in admissions reflecting the post-pandemic normalization. However, in the past 2 years, the admissions have gone up close to 20% from 23 to 25. We attribute some of this to the initiation of our Level 2 trauma program in July of 2024. These are our top 5 admitting diagnoses to the CCU. Number 1 is respiratory failure, which is about a third of the top 5 and 13% of all admissions. Then sepsis and septic shock. We have a new diagnosis that made this list for the first time since our trauma center opened. Traumatic brain injury is now number 3. Coronary artery bypass graft surgery, CABG, is number 4, and then GI hemorrhage. This slide, the bar graph on the left just shows that the percentage of total trauma activations, these are all activations by EMS, the percentage that end up coming to our CCU, it was about 8% the first 6 months that we opened. And this year, I should say the trauma center started, and this year it was up to 10%. What the pie chart shows is that the patients who end up in the CCU are actually a variety of different of the trauma activations. Now, Alpha, Bravo, Delta goes by initially what we think is the clinical severity of the trauma activation, Alpha being the most severe. But we get a good mix of all of the Alpha, Bravo, and Delta. Next slide. Average length of stay in the CCU. The benchmark, internal benchmark is 4.9 days. And although there is month-to-month variation, we remain below the benchmark at 4.78 days. Readmissions. So these are patients who leave the CCU and come back within 24 hours. This is a metric where maybe, if abnormal, may suggest that patients are leaving the CCU too early. National benchmark's 14%. Our internal goal is to have 4% bounce backs within 24 hours, which is 1 out of every 25 patients who leave the CCU. And we're actually pretty solid here. We're 1.2% this year, and generally we've ranged from 1 to 2%. And I want to talk about some of our quality initiatives. This last winter, at the end of last year, we did start some simulation education in the IMC and the CCU. And this is basically practicing rapid response in code blue situations with a mannequin as well as an artificial monitor to create specific scenarios and keep us sharp and ready when the actual events happen. We will plan to continue to do this at least quarterly. Also in 2025, we created a more structured night rounding. We already have a structured daytime rounding, but we made it such that the night intensivist goes from bed to bed with the charge nurse and the respiratory therapist and discusses the plan. And this has improved care and the flow of communication. It actually carries over to the morning shift. Last month, we also incorporated Epic AI patient summaries. A large part of our day is spent synthesizing complex information, sometimes looking through dozens of notes in some of the longer staying patients. And this has been good. This creates us a quick, coherent, and cohesive summary with most of the relevant data. So we have more time to spend taking care of patients, spending less time trying to gather information. So this is the honeymoon period with AI, where it's actually helping us before it eventually displaces us. So next slide. Many of you know about the multidisciplinary rounds. This has been promoted by Society of Critical Care Medicine, and we've been doing it for many years now. And it's a collaboration with essentially all staff members who work in the CCU, and we go through a bundle of important patient care related topics and various checklists. And as you'll see in the coming slides, I think these rounds have really helped to improve a lot of our important metrics. The main goals are to remove indwelling lines, catheters, to minimize oversedation, to minimize ventilator days, and to detect, prevent, and treat delirium in the ICU. Next slide. So here are some of the metrics that reflect our work. Median days on the ventilator for the past 5 years. The national benchmark is actually 5 days, and we have hovered around 2 days, which is a very good. Reintubation rate. So these are patients who are taken off mechanical ventilation, but within 24 hours are put back on. If this was abnormal, it may suggest that patients are being extubated too early. But again, we are way below the national benchmark. We're about 2% this year. That means on average, out of 50 patients we extubate, only one of them are reintubated within 24 hours. We also try not to oversedate our patients. We like to keep them arousable so that they could do rehab and interact. One of the byproducts of that is sometimes they extubate. They pull the tube out themselves. The national benchmark's 5%, or 1 out of every 2 intubated patients. We also have remained way below that, including 2.2% this year. A big topic of discussion is infections that occur in the hospital, and CLABSI is a central line associated bloodstream infection. The terms SIR means standard infection, or standardized infection rate. That's so it's an SIR of 1, which is our benchmark, is basically what's expected for a community hospital our size. SUR is standard utilization rate, and SUR of 1 means the same thing for usage. So you can see for infections on the left, we've been way below 1. We went a couple years with 0 infections. We had 1 this last year, but we're remained below that benchmark. And our use of central lines was hovering around the SUR of 1. And we didn't like that. We wanted to get it lower. So we did get more proactive at removing lines as soon as they were not necessary and not placing them unless they were absolutely necessary. And you see our SUR went from 1 to 0.77 this year. Next slide. This is urinary tract infections from Foley catheters. On the left is SIR. We started working on this we started working aggressively on getting Foleys out. In 2021, we were still hovering about 1 or higher, but last year we came down to 0.6, and somehow this year we had 0. You see on the right side that, it wasn't just the usage of the Foleys, because the usage went down in 2021. But we did other things the past couple years, including more carefully, deciding who we sent the urine sample on, changing the Foley, so on and so forth. And a new layer of vigilance. You see that although the catheter use didn't go down by as much, the catheter infections went down significantly with the additional layer of interventions. Next slide. So I think for a community hospital, especially our department is very good with education, continued medical education. We have the quarterly critical case studies where we take an interesting or challenging case that actually happened in our ICU, presented with an anonymous patient information, and this has been very good. It's an interactive case study. There's audience participation, and this has been well received. In fact, there's one this Friday at 12:30 if you want to attend. Our trauma surgeons have also been very good. We had a couple lectures this year from them. Now that we're a trauma center and get a lot of traumatic spinal injury, we asked one of our neurosurgeons, who's UCSF affiliated, Dr. Seigel, to give a lecture on this. And Critical Awareness Month last May, we had 4 great lectures on the topics that you see, including traumatic brain injury. Next. So our next step is, as I've already mentioned, ongoing increased clinical education, including more regular simulation-based teaching and training. Continue to collaborate with our partners to grow the trauma, structural heart, and neurosurgical programs. And we're also starting to work on some quality improvement projects in conjunction with palliative care to improve end-of-life care and documentation. And we can open it up for any questions or comments.
Thank you very much, Dr. Sheridan. I appreciate all your great work, and likewise to you, Dr. Zizarad. Questions for?
Hard to ask questions for the impressive.
Yeah.
Yeah.
Impressive presentation. Really good stuff.
It's a lot of great work. I guess the question I would have is, why do you think you've done so well with the ventilator statistics? What's your secret sauce?
Part of it, I think, is, we have a lot of surgical patients. I mean, you saw the number of cabbages that we do, and we're pretty vigilant when these patients come out to try to get them off the ventilator as fast as we can. So I think part of it is, we're there all the time, right? It's not like, patients come out, the doctor sees the patient, and then the doctor leaves, right? We're at the bedside all the time. And we're all pretty vigilant in terms of, all right, round on this patient multiple times. All right, now the patient can't wake up and get off the ventilator. So make sure you go back and see the patient again and try to get them off. So I think it's part of that is the fact that, we're there all the time, as opposed to just rounding on the patient once a day and then leaving, going to the office. It's difficult to do that when you're not at the bedside all the time.
Yeah, so it's really intensive care being at the bedside and doing those assessments. Yeah, very good.
Yeah, and then I would add to that in addition to what we do, we've trained the nurses to lighten sedation and do daily waking up trials, and the respiratory therapists, given them, we've trained them so that they start these breathing trials automatically if certain criteria are met, rather than having to call us and ask. So the nurses and the respiratory therapists also now, they work together to do the breathing trial and the wake up trial. So that's also helped a lot.
Excellent. The only other comment I would want to make would be, I don't think you guys have anything to worry about being displaced by AI. I only hope that the AI will reduce your burden of documentation and gathering the information, allow you to get everything that you need to provide the great care that you've been doing. And I hope it eases your day, makes your day go better, and that you can spend more time at the bedside with the families. And that's my hope for AI. Yeah. But I wouldn't worry about you guys being replaced by robots.
Yeah, I was half joking, probably not in my career, but this doctor from Harvard spoke to us about AI a couple of years ago, and her comment stuck with me. She said doctors won't be replaced by AI, but doctors who are not familiar interfacing with AI will get replaced by doctors who are. So.
Yeah, right. It's who can leverage the technology the best.
Yeah.
Appreciate the update. We'll look forward to great work in 2026, and thank you again for your presentation.
Thank you.
Thank you.
Thank you.
Bye.
All right. Next, we've got finance report. Ajay.
All right, thank you.
So as he brings this up, let me say that November was a particularly tough month for us from a volume perspective, and I think you remember this from the last month's report that Kimberly did. However, having said that, our operating indicators are fairly similar to previous months. Our average daily census, patient days, and length of stay were all below budget, just like they have been. Discharges, however, in the past month had been better. For November, we were below budget by 22. Case mix was also strong and 0.07 better than budget. Deliveries, surgical cases, outpatient ED visits all remain above budget on a year-to-date basis, but fell below budget in November. We flexed well on an FTE basis, but due to lower volumes on the keep going. I think we talked about the case. Yeah, but due to lower volumes on the FTE, adjusted occupied bed that was higher than budget by 5%. Going on, mostly due to lower volumes. Gross charges were $15.5 million below budget, and NPR was approximately $1 million below budget. Operating expenses were consistent with budget. However, due to lower revenue, we had a net operating loss of $1.5 million versus budget of $800,000 loss. On a net income basis in the month of November, we had a loss of $411K against a budgeted gain of $364,000, resulting in a variance of $775,000. On a year-to-date basis, we have a net operating loss of roughly $6 million against, net operating loss of $5.5 million versus budget of $6 million, which is, so we are better by about $450,000. On the net income basis, we have a net income of $673K versus a budget of $30K loss, so better than budget by $700K on the year-to-date basis. Moving on, I think I won't spend a whole lot of time on the FASB format. Moving on to our EBITDA, and you can see this first month here actually our EBITDA is lower than budget. We're at roughly $2 million versus budget of $2.7 million. However, on the year-to-date basis, we're still about $610,000 higher than budget, $12.4 million versus $11.7 million. That's sort of the story of the month. It was a tough month. And if you have any questions, I'll be happy to answer.
Any comments or questions? Mike? No. Thank you. Obviously, we're sailing into headwinds.
Yeah. It was when we were about over $15 million less on gross charges. That becomes a tough month.
Looks like things are busier this month.
Things are definitely busier. Even December were a lot busier. Yeah. I'm sure Kimberly will point out shortly.
Yeah.
Very good. Thank you.
So yeah, I will do the operations report for December. It was busier. As we know, there were a number of holidays within the month, so just getting everything together. We're still following up on a few items, and you just want to say that. If you look at patient days, they came in at 5,778. They were unfavorable to the budget of 6,025 by 247 days, or 4.1%. And you'll see that really we have a lower length of stay than what we had budgeted, and you also see that our discharges are over. So one of the things we are working on is an initiative of really making sure that we are having our patients transition to that next level of care or be discharged on a timely basis when, of course, medically time to do so. So that is also, bringing down some of our length of stay. So if you're moving on in terms of our December discharges, they came in at 1,181, which was favorable to the budget of 1,154 by 27 or 2.3%, and was also favorable to December of 2024 by 11.9%. So in terms of those patients discharged with stays over 30 days, it ranged basically from 31 to 54. However, I will say, and I know we've talked about this as a team, we have seen some of our days. We do have a couple of patients in our house that we have one that is over 100 days and another that's a little over 80. So we are working through that. We've had some challenges with discharge plans, given some things with counties and conservatorship. So we may see if those patients get discharged, the days go up from that standpoint. Moving on to our inpatient average length of stay, for the month of December, it was 4.83, which was favorable to the budget of 5.22 by about 8%, and also favorable to December of 2024 by 11.9%. So year-to-date, average length of stay was 4.83, which was favorable to the budget by 7.6%. I will say, and you'll see it on the next slide, that our CMI for December did decrease. And so we're following up on that a little bit more to understand it. So if you look on that graph, you can see our average length of stay for CMI went from 2.73 in November to 3.03 in December. So moving on to that next page, you can see we've broken it down to have a better look at medical versus surgical. And so we did see a drop in both surgical and medical CMI from the prior months. And so we are following up a little bit on that to just make sure everything is documented and aligned and with that. So
do you think that's a documentation issue where we have to capture more diagnoses to optimize
I am not able to say that yet, whether it's just a mix of the type of patients you'll see in terms of our surgical patients, and in terms of some of that mix, we had lower ortho and some of those too. So some of that could have contributed to it. So we just haven't had, we're just in that process of really diving in. We're really able to now, with all the work that we've been doing, we're able to dive in a lot more.
I think it's really helpful to have the tools to do that analysis, to understand the population that we're dealing with.
So we will be doing that. Moving on to our inpatient average daily census, it came in at 186.4, which was unfavorable to the budget of 194.4 by 8 to 4.1%. And again, a lot of this is due to lower patient days, but we're also still favorable to December of 2024 by 13.4 equivalent days. Looking at our outpatient observation days trend, it continues to trend as we know we've budgeted on the conservative side. And so for December, we came in at 202, 111 days, or 35.6% favorable to the budget of 313. And year to date, also favorable by 31.2%. Looking at our surgical trend, total surgeries in December of 545 were unfavorable to the budget of 578 by 5.7%, and also unfavorable to December of 2024 by 4.2%. Inpatient surgeries came in at 299, which was favorable to the budget by 22 or 7.9%. But outpatient surgeries at 246 were unfavorable to the budget by 55 or 18.3%. And we had 4 TAVR cases that were performed in December. So moving on, you can really see the breakdown here in terms of the areas where you could see our surgical activity. There are 4 areas really coming under budget: GI, orthopedics, and really we had both Dr. Dearborn and Saw that were out for a significant amount of time. Together, compared to budget, they were off by 41 cases, so that was the main driver in terms of orthopedics, also urology and vascular. I will note that neurosurgery was very busy, as you can see, with 41 cases. We had 33 inpatient and 8 outpatient surgeries, and they were very busy on the trauma, and we had very high trauma volume, which I will talking about that there were a number of neurosurgical cases that they did. December cath lab cases came in at 189. They were unfavorable to the budget by 21 or 10%, but favorable to December of 2024. Cath lab inpatient cases were of 115 were unfavorable to the budget just by 1.7%, and outpatient cases came in at 74 and also unfavorable to the budget by more, around 20.4%. We did 4 MitraClips and 4 Watchmen that were also done in December. If you take a look at our cardiac cases, you can see in terms of the breakdown in the cath lab, they were under budget by 22 cases, and with the holidays it was slower. Our IR cases, as Dr. Berry mentioned, our new IR group started on December 15th, and they did about 36 cases this month, and our other group did the rest. So it was a busy month, and so I think with our new group, we'll continue to see that volume be there. Neuro IR was up by 1, and vascular, as you can see, was down by 12. In terms of deliveries, they came in at 149, which was favorable to the budget by 4 or 2.8%, and also 1.4% favorable to December of 2024. We had about 30.9% of total deliveries were C-sections this month. And then year to date, we came in at 828, and it was favorable to the budget by 2.2%. In terms of outpatient non-emergency visits, they came in at 9,056, was unfavorable to the budget by 4.9%. Really, we saw this in terms of the holidays impacted many of our outpatient areas. We did do a half-day closure on both Christmas Eve and New Year's Eve for labs, so they came under budget by 10%. Cardiac rehab was also under budget by 8.1%. We had a staff that was out and many cancellations by our patients. And also with the holidays, prenatal diagnostic clinic came in under budget by 19%. It was also offset by infusion center being very busy at 8.8% above budget, and our outpatient wounds also being above budget. Okay, moving on to our emergency department visits. I do want to as we've been digging into a lot of statistics, we did learn that over the this last year, we did double count some of our trauma cases in our statistics in terms of both in the ED and as trauma. So this month in December, we are restating this fiscal year. So it did not impact any revenue. It was not double counted in terms of revenue, but just in the statistics. So I didn't know, did I cover that?
Yeah, absolutely.
Okay.
Yeah.
I would just love to have the insurance companies pay us twice.
Well, we could try that, I guess. But I don't think we'd get very far. So do you want
compliance programs.
I know. We don't want to go to jail.
We don't want to go down that path. But,
and we have counsel here.
Yeah.
Exactly. So our emergency department visits came in at 5,310, which was unfavorable to the budget by 205 or 3.7%, and unfavorable to December 2024 by 3.1%. So in terms of looking at the ED cases, moving on to our total gross revenue for the month came in at $240 million for December. It was unfavorable to the budget by 3.5% or $8.8 million. A lot of that was driven mainly by the outpatient gross revenue being under budget. Year-to-date gross revenue was unfavorable to the budget just slightly by 1.4% or $20 million. Looking at inpatient gross revenue, came in at $3.4 million under the budget of 151 or 2.2%, but was favorable or higher than December of 2024. And so a lot of that unfavorable was due to room and board in terms of dropping that, and also surgical services. I should say dropping length of stay and also surgical services. Outpatient revenue did come in unfavorable to the budget at 89.1. It was unfavorable by $5.4 million or 5.7% due to less observation days and outpatient surgery. You can see in terms of the gross revenue recap, surgical services down 9.6%, driven by our volume being down 5.7%, but also we did have a late charge accrual that was reversed from the prior month. Cath lab is down 10.6% in gross revenue, which aligns with cases being down by that 10%. The others follow the cases, and then ancillary services, as you can see, was up $2.1 million or about 2%. Trauma cases, as I mentioned, was very busy. We had the highest number of trauma cases this month. It was favorable to the budget by 25.8% or 42 cases. Inpatient trauma cases of 86 for December were favorable to the budget of 56 by 30 or 53%, 53.6. And outpatient cases came in at 119, which was favorable to the budget of 107 by 11%. So really busy, as you can see, when we break down in terms of activation codes. Our highest level activation code, alphas, for the most acute patients, we had 16. That was also, I believe, the highest. I know we only go back a year, but I believe that was the highest number of alpha cases that we had. Also high, you can see Bravo and the most deltas too, from that standpoint. The breakdown of those 205 cases, again, 129 falls, which also leads to the neurosurgeries. With that, 37 motor vehicle crashes, 12 other cases like scooter lacerations, stabbings, 12 pedestrians hit by vehicles, 9 assaults, and bicycle accidents. So it was a wide range. I do know they were very busy, especially over the holidays too. Moving on to the trauma gross revenues, you can see came in very high at $28.2 million, was favorable to the budget of $18 million by $10.2 million or 57%. Inpatient trauma gross revenue came in at $21.3, which is favorable to the budget of $12.9 by $8.5 million, and outpatient trauma revenue of $6.9 million was also favorable to the budget $5.1 million by $1.8 million. So 35%. So again, our trauma service was very busy from that standpoint. Looking at our payer mix, the overall government payers were very consistent to budget. We had less Medi-Cal, more Medicare in terms of gross revenue. Then HMO was pretty consistent to the budget. We do see it higher, and that has a lot to do with our trauma cases in terms of that. PPO came in under budget. In terms of gross revenue by 0.7, and both self-pay and TRICARE were pretty much consistent budget. So overall, we'll have to see how, in terms of really where we are with the payer. We were busy, as you can see, and also flexed, given that we just had a high census, and so productive FTEs, plus we have the holidays. For December, we're favorable to the flex by 79.6 or 5.4%. Moving on to the non-productive, also non-productive FTEs for December were favorable to the budget by 28.3 or 12.2%. So overall, looking at our total FTEs for December, they were favorable to the flex by 107.9 or 6.3%. Looking at our total FTEs, you can see per adjusted occupied bed, we came in at 5.75, which was favorable to the budget of 5.99 by 4.1%. So that's just with the high census and holidays. I know staffing was tough, so I don't want to say that, in terms of it, but we had a lot of sick calls too. I know there's a lot of challenges with staffing. And Moving on to radiation oncology, we came in with 255 treatments, which was unfavorable to the budget by 105 or 29%. Again, we're seeing more complex types of treatments, but less treatments per day for our patients. On average, we saw 12 treatments per day in December versus we had budgeted 18. If you look at how many consults for December, we received 31 new referrals or consults. 19 of those were seen in our clinic. We did have a high conversion rate to go through treatment. We had 23% December compared to November, which was at 13%. So continue to see that increase. Washington Health Medical Group overall clinic visits were unfavorable to the budget by 3.2%, but favorable to December of 2024. In terms of being under budget, really, as you know, we had a resignation of one of our ENT docs, so that's our other one is very busy, I know, and trying to take as much take care of the patients as much as he can, but overall visits are down. And also with just the holidays, we had additional time off in our physician. I do, of course, also want to talk a little bit about urgent care. As Dr. Berry said, we opened on December 17th. I do want to say that this budget that was developed probably close to a year ago, and it was scheduled to open in the beginning of November, but as you know, we opened December 17th. And so just with the holidays in a partial month. But we have seen a steady increase in volume in December and into January. We're starting to see an average of over 20 visits per day. We've got a number of, it seems like there are a lot of people that want to have appointments, and so we're working on opening up more appointment slots. As you know, we had an issue with our X-ray that was delayed due to the vendor not having parts. We've got that now installed, and we're just doing the training and getting all of that calibrated. So, but patients have been able to quickly go through fast track and on the hospital to get any of the X-rays that they need. So we are working to get the word out. Again, just that it's open 7 days a week. Over in Washington Properties, which we call next to Walgreens over there, working on ensuring that we get signage and flyers out. So, but overall, we've been seeing the things that we usually would see in urgent care, and hope that people, know that get the word out about the awareness. So.
I know it's too early, but is there any pattern on the visit? Are there more in the evenings and?
It varies in terms of it. As Kimberly talked about, so we open up all the appointments in the morning and the appointments go. So it's actually good for us to have the appointments because it level loads those visits, so to speak. But absolutely in the morning, there's certain days of the week, and I think I gave those to you. We start to see like more people coming in on Monday. I think I don't have my notes with me.
Monday, Tuesdays, and Fridays
are the busier days. Yeah. Interestingly, so definitely Monday.
Sunday was the slowest.
Sunday is slower, so we are starting to look at some of that. We also look at the types of visits that we're seeing. So not reasonable for what you expect in urgent care. So not super high acuity, which appropriate for being seen in urgent care, which is great. Yeah. So we're starting to look at some
and staffing provider-wise, is it an MD or?
It's an MD, yeah. So it is. We have a relationship with Emergency Physician Associates. They have within their urgent care physicians, so they're specifically physicians that are board certified. They've gone through the medical staff credentialing process. So yes, a physician is staffed in that site. Yeah.
Yeah, because there was discussion about using APPs, but we have an MD that is there for all those hours. Yep.
Washington Health, Urgent Care, Maori and Paseo, between Strizzi's and Panera.
And there's designated parking.
Designated parking, good parking.
Walk-ins
10
and
to
appointments.
8 and 9 to 5.
Yep.
And Pete's coffee.
Got it down. And Pete's Coffee is there too. So walk-ins and same-day appointments are available. So
Absolutely.
want to continue, thank you for helping to get the word out.
Yeah.
Yep.
Yeah, I think the full census should be like 32, 36. So on average, urgent care visits are 4 to 5 an hour.
Correct.
Yeah.
So that's why we, we had some newer providers, and not newer in terms of they're learning in terms of just the Epic system, things like that. But we're opening up the appointments, and definitely we should be seeing, 4.
Yeah.
4 is what we want to get to before we then look at a second provider. We have this space, so just so there are 6 exam rooms there, so once we hit that, we can look at opening up more additional as needed.
The demand is there, it's just people getting.
Yeah, we got to get the word out.
People need to know.
Yeah.
that we're here.
Can we get a sign out by?
We are working on
We are
finance.
working on-
That is one of the
Not in
things.
the ED waiting room, please.
Yeah, so temporarily, we're going to look at some of those, and I don't know what they call them, those flag signage. I think you've seen
We're
some of
not going to have
those.
the dancing guys?
No, not the dancing guys, but I know Jerry in our marketing department is looking at that temporary signage so we can get more visibility. As you talked about, Kimberly, we are looking at that but that will take a little bit longer.
Going through the city process is a process, as we know, so that's the long-term goal, is to have, I know Dr. Eapen has brought that up a couple of times, and so that is where we need to go, but it will take some time going through the city processes. So we're looking, as Tina said, at more other.
Yeah, and Jerry in our marketing department also is looking at, boosting on social media with urgent care and things like that. So we're really looking at ways we can continue to get that word out.
And local businesses know that if
Yeah.
something happens to their employees, that we're right next to them.
What about on the fountain?
We will look at all options.
Yeah.
No, seriously, that's a location that's right on the corner.
Apex.
Corner Apex.
That is where the signage was supposed to go, I think, at some point. So, all right.
Okay.
So, moving on to the Development Corporation, the outpatient visits came in at 2,316, which basically were consistent with budget, just about 16 less for December. Rehab Center was right on budget in terms of them. WASP cases were also favorable to the budget by 8 or 1.3%. PSC was unfavorable to the budget by 39 cases, and that was because Dr. Dearborn took some time off, and also our pain management Dr. Banks has left PSC, and Dr. Vargas, who also does pain management, is on personal leave. But really a lot of that was driven by Dr. Dearborn being out.
Yeah.
Moving on to our key financial statistics, you can see our days cash on hand increased 8 days to 110 days. We did get in our IGT payment, about $21 million. We did have it was offset by our medical claims of 2.6 and also revenue bond payment of about $5 million. So, we understand the need to continue to work on building up our days cash on hand. I know Ajay and I have a regular discussion about that, so we will be coming back to the board with goals around that too. The charity care for the month came in at 211. Our rolling 12-month average is 202. Lastly, just looking at our unhoused patients for the first 6 months from July through December, we had 1,037 patient encounters representing 512 unique unhoused patients. And total unreimbursed cost for that period of time was $3.3 million. As you know, that includes food, clothing, pharmaceuticals, DME, transportation, housing, et cetera, for this patient population. So those answer any questions on the financials for the month.
Board members? Very good. Go ahead.
All right, I'll move on to just our employee of the month and then calendar. So I'm very excited to announce our employee of the month for January of 2026. Hennessy Saxdalian. In 2015, Hennessy immigrated from the Philippines, where she worked as a nurse. After working for other organizations, a friend recommended Washington Health, and in 2020, she began working as a unit clerk. A unit clerk interacts with patients, physicians, and members of the nursing staff. Nurse manager for West, Anna Gonzalez, says, Hennessy takes an active role in overseeing patient safety by responding quickly to bite alarms, communicating concerns to the appropriate staff, and efficiently assisting with patient needs to maintain a safe and supportive environment. Hennessy enjoys interacting with patients. She strives to make them more comfortable while contributing to them receiving the best care possible. She is highly valued by her team, and she consistently demonstrates excellent communication skills and an exceptional work ethic. Her dedication, professionalism, and patient-centered care are a testament to the values of our organization. Hennessy's goal is to once again work as a registered nurse. She has completed the coursework and next will need to sit for her NCLEX exam so she can be licensed to work as a nurse in the United States. When she is not working or studying, she enjoys spending time with her 4 sons, ages 3 to 15. Wow. And fortunately, she likes to cook as one of her hobbies. So, we're very excited to have her as an employee of the month. All right, moving on to the calendar. I am I'm just going to have them stroll through the calendar, but I want to make sure that our community knows that if they want to sign up for any of our health or wellness classes, they are available on our website, and they just need to go to the website and then click on the tab that says events and then sign up that way. So. We will go through this. I do want to just make one comment on our UCSF Washington Cancer Center open house. I do just want to recognize everybody. It was a huge team effort to get everybody in terms of doing the open house. And I also really, truly want to recognize our foundation, charitable foundation. As you know, the cost to build out the Cancer Center was over about $22 million, and they came forward and did a capital campaign, and with so many of our organizations in the community, such as Fremont Bank and others, but also individuals who came forward and donated so that we could make this a reality. And so we're very excited in terms of that. I know I've been asked many times about when is it going to open. Our goal was to have it opened on the 19th of this month. I will say we are challenged in terms of all of is getting the Sacramento and CDPH to move forward to come out and do our site visit. So we are trying very hard to get the things moving, but we are ready for them to come. And then we will open it once they give our approval. So we'll keep the board abreast. So, all right.
Great activities out there.
Yes, and there's our urgent care.
Mm-hmm.
And these are the ones, if you want to sign up, to go to our website and to get the information in terms.
I'm going to take this one home and bring it.
We can give you a real picture. Yeah, why don't we do that?
Well, your comments that you made at that, Mike, were just so moving.
Oh, yeah.
Everybody was they're a little emotional after your comments.
I have to chime in on that. Really, really well.
I know.
You can have that one, but we will also give you. You don't know. We'll give you a real picture. All right, that is my couple of reports, calendar for the month.
Okay, we have a singular action item tonight, and I think, Mr. Wallace, you're going to make
Thank you, Mr. President. I need to declare a conflict of interest regarding this agenda item. I am the chairman of the board of Fremont Bank and a shareholder. to comply with the Political Reform Act and our district's conflict of interest policy, I will recuse myself from any discussion, deliberation, or vote on this item. I will now exit the room while this is considered. Please note my recusal in the minutes. Good evening.
You have a great evening.
Thank you.
Bye-bye. Yes.
Okay, Kimberly, if you could introduce the...
We have a resolution this evening for a line of credit, and really Ajay Dial, our Senior Vice President and CFO, is going to speak to it, and I know we also have our other legal counsel, Mary Norvell, with us tonight. So Ajay, I'm going to turn it over to you to make some of those remarks.
Thank you, Kimberly. We're proposing redoing the $20 million line of credit that you'll remember we had a few years ago. It expired a couple of years ago, and we believe it's in our best interest to bring it back. It will have a term of 2 years with an initial rate of 7.25%. It's a floating rate, 0.5% above the prime rate. The reason we need it is for general business purposes and to manage the ebbs and flows of our cash flow, particularly when IGT supplemental payments are due, which are pretty large numbers, double-digit million numbers. It would be very beneficial to have this so we can smoothen out our cash flow. The documents that were presented are final documents, but they will be updated prior to us signing them with appropriate dates and things like that. Mary Norvell is here. I think you all have met Mary before, but let me just take a minute to introduce her. Mary has acted as a district attorney in connection with the line of credit with Fremont Bank. Mary has worked with us on prior lines of credit with the bank. Over the last 15 plus years, she has also acted as borrower's counsel for us on a number of our revenue bond issues and refunding revenue bond issues, as well as a number of the general obligation bond issues. Prior to establishing her own practice in 2015, she worked with a number of law firms, including the national firm of Foley and Lardner, where she worked for 22 years. And I'll turn it over to Mary if you have any comments, Mary, for this, and or if the board has any questions, we'll take that. So Mary, over to you.
I think that the only thing that, as we had talked about, Ajay, was that the bank was going to make sure that the dates on all of the documents comport with the fact that the board is not approving until tonight. So some of the dates are dated January 9th and so on. So they're going to be dated January 14th. And we'll get that probably on, I would say, the next couple of days. Ajay, I think.
Yes.
Okay. And it was a very standard set of documents, similar to what we have had, the district has had in the past. So they weren't difficult to review, but it took a little time because the bank was a little slow on the uptake sometimes. So if anybody has any questions about it, I know that this reading is probably so stimulating that you can't wait to ask me questions about it. But if you do have any, please let me know.
Mary, if I have any trouble sleeping tonight, I know what I will be reading, but I appreciate your comments. Any other comments you'd like to make about the line of credit?
No, I think that the terms certainly are what the district wanted, and the rate is not. Is within the norm for the $20 million. So, and it's we do want to mention that it's interest only until the payoff. So we'll be paying that, but not principal down. I think that's the only other thing. But I do commend the commercial security agreement to you. It's stimulating.
Okay, all right. Thank you very much. I appreciate that.
Thank you. It's all good to see you. See.
All right. Any questions of Bernie, Jacob, any?
No.
All right. Okay. Well, given that, I will entertain a motion.
Mr. President, I move the board approve resolution number 1276 as follows. The district is hereby authorized to enter into the line of credit and the forms of the business loan agreement, promissory note, governmental certificate, and related documents, all in substantially the form attached to this resolution, are hereby approved. Kimberly Hart, Chief Executive Officer, and Ajay Sial, the Senior VP and CFO, are hereby authorized on behalf of the district to execute the bank documents required in connection with the securing the line of credit. In the event that the bank approves an extension of the term of the line of credit, authorized officers or any of them are hereby authorized on behalf of the district to execute amendments to or restatements of any or all of the bank documents as may be in the best interest of the district, provided, however, that any amendment that increases the principal amount of the line of credit shall first be approved by the district board of directors. The authorized officers are hereby authorized to take any and all actions necessary to execute any and all instruments and do any and all things deemed by him or her to be necessary or desirable to carry out the intent and purpose of the foregoing resolution. The first Vice President is authorized to sign this resolution in place of the Secretary due to the recusal of the Secretary from the discussion and vote concerning this resolution.
Thank you, Dr. Ethan. We have a second from Dr. Stewart. Any comments or discussion from the board members? Paul, is there any need to open this up to public hearing?
Just ask.
Huh?
Ask.
I'll open this up to public hearing and ask for any comments from the public. Hearing none, Cheryl, if we could take a roll call vote.
Director Nicholson?
Aye.
Director Yee?
Aye.
Director Stewart?
Aye.
Director Epen?
Aye.
Motion is approved. Thank you very much.
I'll sign this. Okay.
Yeah.
Thank you.
All right, and then Kimberly, any announcements?
I have no announcements.
Very good. So there being no, and any concerns or questions from the board members? No? Anything we need to address?
There's no need for a closed session.
Right, I understand. Thank you very much. And so there being no business before this, no further business before this board tonight, we will adjourn.